Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1. Questions 1 to 12. You hear a GP talking to a patient called Daniel Anderson. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, it's Daniel, isn't it?
Yes, Daniel Anderson, that's right. Hi, Dr. Hampton.
I haven't seen you for quite a while. What brings you in today?
Yeah, I probably should have come in before now.
Okay, well, that's fine. So how can I help?
Well, basically, over the last couple of weeks, I play football on Sundays, and a bit more than a couple of weeks ago, I was getting a bit more tired than I used to be. Like, I'd get out of breath in the game, I'd get puffed out. But more recently, it's been little things like walking up and down the stairs and stuff like that. That's got me a bit tired as well. So I was just wondering what's wrong with me, really?
Okay. When did you first start feeling poorly? Can you remember?
That's the thing. I had a cold, you see. Well, I thought it was a cold. I had a sore throat, and I was quite under the weather for that, but I've never really recovered since then.
And how long ago was that?
That'd be about a couple of months ago now.
Couple of months. Did we see you with that?
So I made an appointment on the phone, but I didn't come in the end.
No, I didn't see you on the computer. So you just basically managed that yourself and...
Yeah, I thought it was getting better, but it's never really... I suppose that's never really gone away entirely. So maybe it was something more than a cold. I don't know.
Okay. What symptoms were you getting with that cold at the time?
Bad sore throat. My glands felt quite big as well. So I was just really tired, really, no energy.
Were you short of breath at that time during the cold?
Yes, but not as much now. That's why I've come in now, because it's gotten worse. It's got a bit more noticeable. But the cold symptoms have gone away now, pretty much. I still get a bit of a sore throat every now and again.
Right, okay. When you're at rest, do you get short of breath?
No.
No. Okay. Ever had asthma?
No, I've never had asthma or any sort of chest problems as far as I can remember. Nothing like that.
And do you have a particular diet? Are you a vegetarian or anything?
No, I'm not a vegetarian, but I hardly eat any meat either. I eat a lot of fried rice and instant noodles from the university cafeteria. The food's quite cheap. I know I should eat fruit and vegetables, but I'm a student. I suppose my diet is terrible if I think about it. Some days, all I'd have is instant noodles and some hot chips and the usual 4 or 5 cups of coffee.
You drink a lot of coffee then?
Yeah, it keeps me going with all the assignments and things.
Okay. Have you noticed any problems with abdominal pain or indigestion?
No, nothing severe, no.
Nothing severe? Have you had some from time to time?
No, not really. Well, I've had some mild discomfort occasionally, but that could just be indigestion, I suppose. I don't know, it's something I've had on and off for years, really. It's nothing new.
It's nothing new, okay. Any nausea or vomiting with this?
No.
What about your bowels? Have they been working normally?
Yes, been fine. I haven't had any diarrhea or anything.
In particular, not past any black or very dark motions?
No, nothing like that.
And what about family history? Is there a family history of people getting anemic, for example, for any reason, as far as you're aware?
No, not that I can think of.
No one's had any sort of blood disorders or anything?
No, nothing like that, as far as I'm aware. My parents are very fit and active, and my brother doesn't have any health problems that I know about.
Right, so they're all fine as far as you know. So, Daniel, did you have an idea in your own mind what this might be?
I thought it maybe could have been related to the cold I had because one of my friends did have glandular fever around like a few months ago because my glands were up. I thought it could be related to that.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Come in, Mr. Murray. Oh, I see you've got Kate with you.
Yes, that's right, Doctor. She's had an accident at school.
Oh, dear. Well, I'll bring you both in here and get Kate comfortable on the couch first.
Oh, good. I think she's in quite a bit of pain.
Yes, obviously, and she's looking very pale. Now, can you tell me what happened?
Well, she had a fall at school, actually. It was in her gymnastics class, and I don't know, I think she landed awkwardly in one of the practice exercises.
And how long ago was that?
Well, the school called me to pick her up, and I came straight here, so about an hour ago, I think.
All right. Now, before we go any further, how old is Kate?
She's 7.5, Doctor.
Is she on any medications at all?
Well, she gets occasional asthma attacks, so she uses a venter inhaler when necessary.
Okay, and no other illnesses?
No.
Now, looking at Kate's right leg, she does have a nasty bruise developing as well as some swelling, so I do need to take an x-ray. Well, I've got the x-ray results here, and it's a spiral fracture of the right tibia.
Oh dear, I was hoping it'd just be a sprain.
No, it's more serious than that.
I see.
Now, I've rung the fracture clinic at the hospital, and they've advised that we can't put a cast on while there is that swelling.
Right.
But they've asked me to put on a back slab cast while there is that swelling, and also a bandage to keep that in place.
I see.
Has she taken anything to relieve the pain yet?
No, not yet.
Well, I'll prescribe her a medication known as Pain Stop for Children. It's specifically formulated for fractures and contains both paracetamol and codeine.
Right.
And it's in liquid form and fast-acting.
Oh, good. And how often did she take it, Doctor?
For her age, she can take 10 to 12 ml every 6 hours until the pain subsides.
And how long do you think that will take?
Within 48 hours. But I do want you to contact me if pain persists longer than this.
Will do, Doctor.
And the other thing is plenty of rest for the next few days. Now, we'll need to set Kate up with some crutches, and you can get them from the pharmacy across the road.
Okay.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a nurse in the emergency department discussing the care of a patient with a doctor. Now read the question. So, who have we got here?
This is Adam King. He was brought in with a dislocated shoulder. He has Marfan syndrome, so we've seen him before with this. Last time he was here, the shoulder popped back in while we were putting his arm in a sling, and he was able to put it back in himself just by relaxing his muscles, but he's in quite a bit of pain right now, so he's having trouble calming down and getting those muscles relaxed.
Right, I see. So, do you want to start with some nitrous and some pain relief?
Yes, I think that's best, just until he calms down.
Question 26. You hear a trainee doctor discussing a patient diagnosis with a tutor. Now read the question.
Let's have a quick chat about the diagnosis for Janine in Ward 2.
Yeah, I was a bit unsure about that one. Because it's a young patient, it's not going to be diverticulitis or...
Well, it's possible, but she is young, so yeah, it's unlikely. So, what do you think? What else could it be? What else happens in the bowel? Something common. Think about common things.
Bilateral lower abdominal pain? Because it's like radiating into the back?
Yeah, something very much more common than that.
Gastroenterological?
Yeah,
I can't think.
possibly related to diet?
Celiac disease?
Perhaps, but there's not a lot of other symptoms pointing to that. What else would give you discomfort in the bowel? Lower abdominal pain.
I suppose if they're just constipated.
Right, yeah, constipation.
Question 27. You hear a hospital nurse briefing a colleague about a patient recovering from elective surgery. Now read the question. So, who have we got in bed 8?
Bed 8, Mr. Bernard Chambers, a 50-year-old man, had an elective bilateral inguinal hernia repair this morning. His wound is covered and dry and his post-operative observations are stable. Temp is 37, his blood pressure 140/70. He's already started eating a little and his walking is tolerated. Analgesia is written up but he hasn't needed anything. He's planned for discharge tomorrow. His wife can pick him up. And he'll need a sick certificate for work before he leaves. Can you make sure he gets that, please? I asked the ward clerk to copy some post-op information for him, but I haven't had a chance to look through it with him.
Question 28. You hear 2 hospital managers talking about an information session for people who want to do voluntary work. Now read the question. So, how's the planning going for the future volunteer information evening?
Well, we've had a lot of RSVPs already, so I'm really happy with the way the event management systems have worked. Having a bit of trouble sourcing some good catering, though. Considering that these people are freely giving their time to come and learn what is expected, I really want to provide some nice food and refreshments for them. Have you got any contacts you like using?
Yeah, look, that's right. It's a small thing we can do for those participants. I'll tell you what, I'll ask around my team for some recommendations for something a bit special.
Great, thanks. I really appreciate it.
You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Anderson. I just wanted a quick word about Mrs. Campbell's prescription. The one for diphenhydramine that you gave her last week.
Ah, yes, for her allergies.
Yeah, so she's been taking 50 milligram tablets for about a week now. The thing is, she's just been into the pharmacy and she says that the tablets are making her feel really drowsy and her mouth's really dry, ever since she started on the pills.
Really? Well, that does happen from time to time. But maybe switching her onto a different medication wouldn't be a bad idea.
Okay, I'll look into some options and then run them past you later, shall I?
Fine, thanks. Question 30. You hear a doctor advising a patient about a change in medication. Now read the question.
Now, the good news is that I don't think that antibiotics are going to help, so we don't need to think about those. And what I'll be advising actually is, from now, I'll be advising to start with a daily antihistamine. It's called cytarabine. I'll write that down for you because it is cheaper to buy than it is on prescription. And it probably is the number one choice for, I hope you don't mind this bit of scrappy paper
That's okay,
here.
that's okay.
The number one choice for hay fever at this stage. This is 1 tablet a day. Now, for most people, it's absolutely fine. One person in about 100 gets a bit drowsy with this, so if you find when you've taken this that you get drowsy, then it could be this, and we maybe need to think of other options, and we'll come back to talk about that.
That is the end of Part B. Now turn over and look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Anemia commonly complicates heart disease. Despite its association with poor outcomes and a biologically plausible argument supporting anemia correction, we found little evidence that use of ACE as erythropoietin-stimulating agents, or blood transfusions improve health outcomes in patients with heart disease. A limited evidence base consisting mainly of one trial suggests correction of iron deficiency in patients with symptomatic heart failure improves exercise tolerance and quality of life. By far, the largest number of trials has examined ACE in patients with heart failure, and most of these included patients with systolic heart failure. Though a grouped analysis of these mainly small, Single-center studies show some initial promise that ASAS may improve exercise tolerance. The evidence base is limited by inconsistent findings across trials, with some finding benefit and others finding no effect. There are a number of possible reasons for the discrepant results, including differences in patient populations, treatment dosing and formulation, and outcomes examined. For example, the largest of the trials 19 enrolled slightly older patients and achieved a slightly smaller hemoglobin improvement with DSA use than did other trials finding a benefit. However, our analyses suggest that the clearest contributor to the discrepant findings was the quality of the individual studies themselves, with the poorer quality studies generally supporting a greater benefit from ASAS and the more rigorous trials finding a neutral effect. Our review differs from a similar recent review of ASAS 72 for three main reasons. 1. We evaluated studies in both heart failure and CHD patients, though most studies focused on heart failure. 2. We conducted additional analyses investigating the impact of study quality on the overall results. And 3. We included studies of patients with advanced kidney disease if there were separately reported data for the subgroup of patients with comorbid heart disease. We felt the latter difference was justifiable because kidney disease is common among patients with heart disease, and we felt these data were important in understanding the potential benefits and harms in this population. Though there were few excess harms reported in the smaller ESA trials of heart failure patients, the excess risk associated with ASAS and CKD populations 73 and cancer populations 74 is of concern. Moreover, our own analysis suggests the potential for serious harms associated with aggressive ESA use among the large proportion of patients with heart disease and comorbid CKD. On the other hand, these data may not apply to patients with symptomatic heart failure and reduced systolic function, and they do not elucidate the role of less aggressive ESA use, leaving us with very limited evidence with which to truly evaluate the balance of benefits and harms of ASAS in patients with heart disease. While the large RED-HF trial should more definitively establish the balance of benefits and harms of ESA use in patients with heart failure, the current uncertainty of benefit and the possibility of significant harm suggest widespread use of ASAS in patients with heart disease may be premature. For patients with comorbid chronic kidney disease, the recent cautious FDA recommendations seem reasonable, as they acknowledge the uncertainty of the role of ESA use and suggest that, if they are to be used at all, patients should have HGB of at least 10 grams/dL.75. There is good evidence from one methodologically sound, large multi-center trial that intravenous iron carboxymaltose improves exercise tolerance, quality of life, and exercise duration in patients with chronic, stable systolic heart failure. 33 These results are most applicable to iron-deficient patients with NIHA Class III heart failure. Relatively few patients with milder degrees of heart failure were included. It also may be premature to apply these results to patients with more subtle evidence of relative iron deficiency. Biologic plausibility and test of concept studies suggest iron replacement could play a role in improving symptoms of heart failure even when, theoretically, iron stores are adequate because symptoms may be related to a functional misuse of iron rather than absolute deficiency. Nevertheless, though the criteria used to define iron deficiency were fairly broad, most patients enrolled in the FAIR-HF trial had evidence of more advanced iron deficiency and limited iron stores. Finally, though these results are encouraging and have the potential to influence treatment of heart failure, the long-term health and cost implications of this are uncertain, and harms have not been more widely assessed. Despite a paucity of data to support this contention, for decades, many physicians adhered to the 10-30 rule, transfusing patients with hemoglobin under 10 grams/dL and hemoglobin under 30% for perceived safety reasons. In recent years, recognition of immunomodulatory effects from leukocytes contamination and changes in RBCs with storage that impair oxygen exchange have led to increased scrutiny of RBC transfusion practice, culminating in the TRI-Trail. After its publication, there was widespread adoption of more restrictive transfusion standards. However, because oxygen extraction is already maximized in the coronary circulation, concern has remained that patients with coronary stenosis, who cannot increase blood flow to enhance oxygen delivery, will be more susceptible to ischemia in the setting of anemia and therefore, should generally be transfused to a higher target than the general population. Often, this continues to be a hemoglobin of 10 grams/dl. In the perioperative literature, accumulating evidence from randomized controlled trials supports use of a conservative hemoglobin trigger no higher than 8 grams/dl among heart disease patients in the intra and postoperative setting. The results of the FOCUS trial, by far the largest study to investigate transfusion use in heart disease with over 2,000 enrolled patients, have thus far been released only in abstract form, but it found no difference in mortality, ability to walk across a room unaided, falls, or readmissions with transfusion at threshold of 8 versus 10 grams/dl. While they have some methodological weaknesses, 4 randomized controlled trials in cardiac surgery, 1 additional study in hip fracture, and 1 trial in vascular surgery all were consistent in finding no difference in mortality or other health outcomes with more restrictive use of transfusion. No similar trial has been conducted in the general surgery population.
Now turn over and look at Extract 2. Extract 2. Questions 37 to 42. You hear a presentation in which a researcher called Dr. Milan Petricevic is talking about the relationship between new technology and medicine in the future. You now have 90 seconds to read questions 37 to 42. Hi, I'm Dr. Milan Petricevic, and today I'd like to talk about the future of medicine, particularly in relation to the current technological revolution. To many of us, it seems inevitable that medical robots, automation, and artificial intelligence will replace many jobs in healthcare. Surgical robots are becoming increasingly more precise, and right now, man-sized robots can lift and move patients and transport them throughout a hospital. Silicon Valley investor Vinod Khosla once said technology would replace 80% of doctors because machines will be more accurate, objective, and cheaper than the average doctor. He added that eventually we won't need doctors at all. However, I disagree. Instead, I think technology in some specialties will finally allow doctors to focus on what makes them good physicians, treating patients and innovating, while automation does the repetitive part of the work. So let's look at some examples of how different areas of medicine will benefit from current technological advances. Take general practitioners as an example. Many doctors choose this specialty today because they have a chance to make a long-term impact on someone's life. And it's true that GPs enjoy tremendous trust from their patients. But seeing someone only when they are sick makes it hard to prevent disease and ensure someone's long-term well-being. It's even harder to do this when waiting rooms are overflowing and you only have 15 minutes to diagnose the illness, design a therapy, and offer health advice. In the future, wearable sensors and devices that stream data to a doctor's smartphone will notify them whenever vital signs are acting up and provide them with all the data they need wherever they are. These devices will also ensure doctors only treat patients who really need professional care, making it possible to offer simple treatment advice remotely. In turn, this will increase the time GPs have to treat and advise each patient, building trust and ensuring patients act on a doctor's advice. What's more, smart algorithms will allow GPs to tap expert advice on their patients' conditions and act as a gatekeeper, connecting patients to other specialties. And these are just a few examples. So what about radiology? Well, already IBM's medical sieve shows how artificial intelligence algorithms can scan hundreds of radiology images in seconds, doing the repetitive job of finding malignant or out-of-place phenomenon that currently radiologists have to do daily. This technology won't replace this important specialty. Instead, radiologists will have time to supervise how the algorithm is doing, or to research and innovate, making the technology behind these devices even better. Their time will be much more productive rather than spent checking hundreds of x-rays a day. Ophthalmology will bring science fiction technologies to patients in the near future. Retinal implants might give vision back to those who have lost it, or even give humans supervision, augmenting what we can already do. In sports medicine and rehabilitation, the first forms of activity records from tech like Fitbits all focused on people who exercised regularly, but only provided basic insight into how they were performing. Now, a new generation of devices tailored to professional athletes is hitting the market, with apps providing detailed insights into movement patterns and force output in any movement. Sports medicine physicians will have concrete data to measure how athletes are improving. By the time these reach the mainstream public, sophisticated algorithms will be ready to analyze data from these devices and provide personalized suggestions to improve performance and to speed up recovery. Similarly, video consoles from Xbox to Microsoft Kinect will offer a way of monitoring how a patient is doing from a distance by seeing their progress liquidly on a screen. In oncology, this specialty will pave the way for personalized medicine. Even now, oncologists customize therapies to a patient's genetic background and their tumor's molecular makeup. Cheaper genome sequencing and measuring blood biomarkers are speeding up this process, with companies like Grail working on fluid biopsies which could filter tumor cells from blood samples. Tumors could soon be diagnosed earlier and analyzed without costly surgery. What's more, artificial intelligence could soon be used to help oncologists understand and even cure cancer. Already, IBM Watson obtains all the relevant information from millions of studies about a patient's case and makes suggestions for treatment plans most likely to work. In the meantime, patients are better informed about the disease thanks to social media communities of fellow patients. These signs all point to a bright future for oncology in partnership with new tech innovations. So what does this all point to? Well, my conclusion would be that, all in all, many jobs will be taken over by robots and automation in the coming years, but at the same time, amazing opportunities will also emerge, especially in medicine. These will require physicians to acquire new skills and improve their existing ones. In my opinion, the majority of specialties will have more time for patients and better insight into disease. That is the end of Part C. You now have 2 minutes to check your answers.